So
So
yeah, I think if
you were
you,
just talking about that, the study, right?
yeah, so if you look at like FAI, how it came about was, I mean, Reinhold Gans in 2003 published this article that, hey, this is what I'm seeing in surgery. And so it was a pretty much a case, a self-reported case of here's what I'm seeing, which is exactly what Charles Neer did. And if you look at what happened with subacromial impingement syndrome, is like that's kind of almost been debunked at this point. So if you look at the basic science studies, so these are all of the top 50 cited articles on FAI. Only 5% of them are basic science studies, which is, you know, biological plausibility. I mean, is this truly what's happening? So it's kind of
Yeah,
crazy.
it's we tend to see this, it seems like, a lot. I know one of the recent ones that I paid attention to that was emphasized is the whole acute chronic workload idea. And the vast majority of studies published on it are editorials and opinion pieces, which is, yeah, a little bit of a, maybe cart before the horse. I think PRP, yeah, I don't know if it's a funding thing like we were talking about earlier or what, but everybody seems really eager to go get to say, if I do this, what's the outcome, as opposed to establishing any sort of, that's whatever they call it, nomenological network of validity support to this. Like, we need to understand basic principle of what is actually happening here and how do we dose it, just like anything else, right? So it's,
Yeah, and I think unfortunately, well, and I can expand on this later, but I think it's too late for FAI. I think the train has left the track. So
well, every time my hips kill me, I just say, I talked to Mike and I talked to Eric, and they both shrugged and said, we don't know. So I assume I'll get a total hip at some point. But before that, don't go through 3 years of pain and suffering. Every time I stand up from a chair and both hips pop and I drop a little bit, my patients look at me weird. Don't worry about it.
I'm good.
I'm getting ready for my total hip here. So yeah, anyway, from a casual chat perspective, thanks for being on, Mike. We've been looking forward to this one. Force myself to stretch. Stretching is useless. So Shelby just said, force myself to stretch. I will say somebody was way back when the mobility WOD stuff was popular. They're like, yeah, try out some of that. Man, worst thing you can ever do for FAI is use a band mobilization and a kettlebell to push you into range. Yeah, so tried it, Shelby, didn't work. But as far as this, the main thing is talking about something that's interesting to you. So I know FAI is probably where we'll start, but doesn't really need to stay there. And one of the things I was going to bring up is specific to the sports performance. You published one of the first articles I remember seeing kind of on strength and conditioning rehab with, was that Dan Lorenz?
Yeah.
When was that? Was that like 12 or?
I think it was like 2011 or 2012, somewhere in there.
Yeah. Does that still get cited a lot?
It does. It's so, like, as you know, you can get an H index and you can see like how many articles are cited, and what is interesting, and that typically it is kind of dependent on like researchers citing your work and that type of stuff. And so probably not as much as, but like every year I go to CSM, or like I probably get more direct feedback on that paper than any paper I've written versus, but it still gets a decent amount of citations. And so, it's probably
I
more
was
what I get.
curious because that periodization one that Lorenz and I did, it's just constantly ticking up, and it's not like hundreds, but I think we're closing in on 60 at this point, which I would have never anticipated for just a random one-off. And it's just pretty much the same amount every year. It just keeps, anytime someone, yours is almost always in the same paper when I check. So I was curious about that. But I guess FAI, right? You're the hip dude, right? You're the hip guru, or whatever honorific we utilize. So speaking of it in the sense of high performance, because and I'll let you speak to this more directly, but I know just anecdotally and what I'm aware of in the literature, you see it a ton in high performing athletes, especially cutting, turning type sports. So, um, like, I don't know what's interesting to you about FAI at this point. I mean, it's hot now. It isn't. Where are we?
Yeah, it's definitely hot. Yeah, a so this pretty interesting Femi Aini, who is a Canadian surgeon, uh, he orthopedic surgeon. He actually led the first, so it's FIRST, the first group. I don't, if I'm
Hmm.
last step or impingement, some I don't remember what it stands for, but essentially they compared a sham surgery to a surgery, and and we can talk about that too if we want. But my point is, like, he wrote an article called about FAI, are we at the tipping point yet? And
Hmm.
um, if you look at from I think like 2013 to or maybe 2011 to 18, over that 7-year period, the rate of surgical uptake was 26-fold or 2,600% higher in 2011 than it was, or in 2017 than it was in 2011.
Oh, wow.
That is at least 10 times higher than anything else, even like subacromial impingement or anything. And so so part of the problem is, I mean, probably some of that growth is necessary because a lot of these patients, if you look at the literature, they've had this pain for a long time. They've seen multiple providers. They're frustrated. But it's still the new kid on the block, and like everybody wants to do it. And 600% of that growth is typically coming from new surgeons
Mm.
who, by nature, I mean, as you know, like new clinicians tend to make a few more mistakes. They have more kind of issues post surgically. So yeah, it's exploding.
So I did not realize that it was still on that same growth. I thought it was
Well,
slowing down.
I think it is slowing down, especially in Europe and like Australia, they've kind of put some, I don't know if regulations is the right word, but like it's definitely starting to level off.
Gotcha. And is that, I mean, sports med especially seems to do a fairly good job of looking at the literature and adjusting somewhat, compared to it. Like you look at some of these, meniscus is a great example of people. Oh yeah, we used to do a lot and don't. Do you see FAI kind of going that way, or do you think that it'll keep that resurgence?
Yeah, it's a good question. I think it definitely will level off. I think the issue that FAI has, and I mean, I'm a part of this as well, is the majority of our evidence is level 4, so case cohort type of stuff. And if you look at I mean, I think there's that one sham surgery, and then there's 4 randomized controlled trials comparing PT to surgery. But there's like 6 meta-analysis on those 4 randomized controlled trials. That's how crazy we are.
Mm-hmm.
And the majority, so even as it grows, what happens is the growth primarily comes from level 4 studies. And like, the issues that come, I mean, the level 4 surgical studies. And so what you tend to see is the effects are like medium to large versus in the randomized controlled trials, they're small.
Right.
And there's various reasons for that. So
Yeah, I think it'd be worth like touching on when you're looking at a level 4 versus an RCT. What are like your top couple things that you're like, this is why I would say, those effects are so much larger in a level 4.
yeah, so probably that's a great question. I mean, obviously, first one that most people talk about is like selection bias. I mean, it's, if you look at the literature, like if I walked into my to the surgeon's office that I work with that sees FAI, and there's 10 people sitting in the waiting room, there's probably 9 of them that have FAI just because they've been kind of farmed down to him or her. And so selection bias is a big issue. I think what's very interesting is, so a colleague of mine, Chad Cook, is starting to do some mechanistic type of studies,
Hmm.
essentially kind of getting into like, okay, what are the mechanisms for the effects? And most people would look at a cohort study and say, well, it's biased because it's, sampling and that type of stuff. And then if you combine those cohort studies um, in like a meta-analysis, some of that effect washes out a little bit. So it goes from like large in certain surgeons' offices to like medium to low. And so how you might also look at it as well, maybe it's some of the placebo effects, right? Maybe that surgeon that sees only, so like Benjamin Dome in Chicago, if that's all he does, he has the American Sports Hip Institute, that's all he does. And like he's probably technique is much better, but also his therapeutic alliance with the patient, like
Hmm.
they know who they're like. So I think we can't discount a lot of that stuff.
Yeah. So, I mean, I guess the big thing is the whole point of a well done RCT is that we remove a lot of the things so we can actually get a better estimate of the causal influence of the intervention on the outcomes we care about. As level 4 is more of a looking in the door and seeing what's happening in the room, with a
Yeah.
little bit less understanding. So anything else specifically around the research side of stuff on, and not specifically just FAI, but hip in general, that's kind of piquing your
Well,
interest?
yeah, I think definitely the level 4 stuff. I mean, like you were talking about, not a lot of external validity and some of that kind of stuff. I think from an outcomes standpoint, and like I posted something like this on Instagram, but like I have this slide I always do in my talks, and it's so we did this meta-analysis in British Journal of Sports Medicine in 2018, and we found return to sport rates. So return to sport rates are, like I've published 4 or 5 papers on return to sports for like Tommy John, a couple different things, and they're very frustrating papers to do because defining return to sport is very frustrating.
Man,
It-
let's stop on that, because that is such a big issue. Like, not just, I mean, obviously in the research, but in any organization as well. When everybody wants to know, when is this person ready to go back? Nobody knows what going back means. It's never operationally defined. We have no, and a ton of the things are just based off of the tests that we're capable of doing, as opposed to ones that tell us anything about that. So continue that, but or circle back around later. But that is such a big thing, especially in a performance type setting of, like, you hit the nail on the head. There's no understanding of what this is. And so how can you have any discussion around it when you don't know what the endpoint is?
yeah, no, it's huge. I mean, this could be a talk by itself, but I think so from a literature published standpoint, return to sport is very frustrating because, like we had 35 articles, for example. Some of them define return to sport as they were on the roster. Some of them defined it as they played in at least one inning or one game or whatever. The I would suspect that most patients, meaning at least the majority of my patients that are athletes, the reason they have surgery is so that they can go back and play like they did prior to their injury, which Claire Ardern in her ACL paper called, that group called it, that would be return to performance. But even that definition for me is lacking because that definition doesn't account for statistical analysis. So like
Mhm.
in baseball, for example, wins above replacement
Mhm.
in that type of stuff. So, so is this guy going back to AAA after surgery? Is he batting the same, RB, is he batting the same average? Yeah, if he's in basketball, is he scoring the same? There's obviously a lot of issues that go along with this because, if they're on a different team, they're a different coach, or they're going from high school to college, different offense. Like there's all, I think this is a thing that's going to be very hard to wrangle.
Mhm.
And so from that literature standpoint, I think from a standpoint of determining return to sport for the athlete in front of you can be very complicated. And so I think it's, well, like what I do in rehab learning centers, we talk about different cases, and that's pretty much why I came up with that. We do some cohort stuff, and in one of my courses is simply 3 cases, and we just go through those cases and we just like go from them from beginning of return to sport to the finish. And like I give examples of what I did, but essentially needs analysis. Is this a hip impingement type of a sport? Is this an endurance based sport? And so there's different categories. Then what, if they're a soccer player that's a forward, okay, well, what are the work to rest ratios? How long are they running? Like, how long are they at rest? But the problem is, if you look at the literature, that's for Division III soccer players that are female. So I tend to like every kid has tape. Bring in your tape and let me watch, what you're doing, and, go from there. So, like the one, I saw this funny quote where Messi, I forget the exact numbers, but it's something like Messi is only like sprinting 18% of the time. And they say, well, make the 18% count. So, but it's just knowing that, what he does. So,
Right. Almost that polarized training, right? 80-20
yeah.
split, right? Yeah. And I mean, expertise is knowing when to sprint, right? The worse you are, the more you have to sprint to catch up where you thought you were. It is such a complicated, messy topic, and ties into the same of injury risks. Like, people will talk about hours of exposure, but what is an exposure, right? So 3 injuries per 1,000 hours, but is that practice? Is that playing? Were you sitting on the bench during that time? Was that total games? Were you out there were you standing around in the backfield? It's such a, yeah, when you actually look at this, it gets messy. And that's what I think, that tip of game film, every kid has it for the most part. And if you don't have time to do it, just tell them, I want you to go home and watch 3 of your games. And every time you do this, mark a start and mark a stop, and bring those numbers in to me. Like, at the very least, that just really gives you a little, and then it's making them invested in what they're doing. They feel like they're doing something specific to it. So, that's mostly been the, from a FAI, so limited stuff. Shelby had a comment, I think it's interesting, of the sort of the opposite, more of a dysplasia thing. Are you seeing similar things around that, or is that a whole different ball game for you?
For dysplasia.
Mm-hmm.
Yeah. So it's, well, we published there's a Warwick agreement that we published. So I was fortunate enough to be on there. And then we pretty much the same author group tried to come up with a consensus paper. So Franco was on there as well. And the one that I led was consensus on kind of breaking down the Warwick agreement specifically into like FAI, dysplasia, and then other things that, like cartilage and that type of stuff. And we were in a room in Bern, Switzerland for like 8 hours, and we were arguing, well, not the whole time, but the issue, I mean, these are people in the field that have published on this. And so the issue with dysplasia comes into is that mild dysplasia, which is considered center edge angle 20 to 25, and versus less than, and it's even sometimes then people don't necessarily agree. What is that, an AP view? What view, is that type of view? Is it a anterior center edge angle? So we kind of came up with some general types of things, but brief answer is yes, it's the same. And so FAI is, so the hip is probably 10, 15 years behind the shoulder, which is probably behind the ACL. And so as far as research wise, and FAI is the most prominent one. Dysplasia is even further back. I mean, just because it's not as many people are dedicated to research to it. There's a really good group out of Denmark that's doing some really cool stuff. Julie Jacobson is doing some really cool stuff. And I think the same with it as with FAI. I think it depends on a good program, because she's showing a very disciplined, progressive program. Makes a big difference on these people versus not. So
When you
hopefully
say,
I answered the question.
yeah, when you say a good program, what does that mean to you?
Well, to me, it means progressively loaded. It means measuring things like rate of perceived exertion, like getting a lot of data and then systematically progressing it through different phases, taking into account the patient's goals, taking into account. So like I teach my students in this acronym that I call EPIC, Epic Return, which is pretty much based off of Greg Lehman's Build It Up, or Calm It Down, Build It Up.
Mm-hmm.
And in there I talk, so like the C is considerations, and to me is like, maybe I think you need to be experienced treating these people. Like, I mean, some, like if you look at ACLs and you look at the Greenberg study in JOSPT, what was it, like most of them were OCS and SCS, but 55% of those people use manual muscle testing as a strength measure for return to sport. And so
Bad.
that's not good enough. So, so my considerations is, are you the best person to treat that person? So,
Gotcha. Specific to that programming, we see at the shoulder some of this research coming out where the idea that the exercise itself is probably less important since the cuff kind of is engaged with everything, and that one off with the was it Radcliffe where they did just the lateral raise compared to everything else and found similar. Do you find the hip is similar, or does the hip, because of its nature, actually require us to consider more specific loading, or is it kind of like, do something and progress it and the hip will respond?
that's a great question. And to be honest, like those papers kind of opened my eyes and made me self-consider and reflect on that. I think, and maybe, but I would have to, like, I think it depends on the person. So like last year, so every year I go into a different clinic. Last year I was in our football training room. I think the prescription needs to be different there. And if nothing else, it's going to be because the strength coaches are there, versus, a more traditional outpatient clinic. Somebody, depends on what the patient's goals are. And, like how much they want to be involved, how much they want to come in. I do think that, and I've been guilty of this myself, I think we tend to give like too many home exercise programs versus maybe focusing on a few and making sure they're really good at those, and then changing those out or progressing them. And so, yeah, it'd be interesting to try to replicate that type of study in FAI or dysplasia, for example.
What would, off the top of your head, lateral raise for the shoulder is what for the hip?
Yeah, that's a good, probably, well, I'm
Smart.
kind of biased to like standing hip abduction,
Okay.
or maybe like banded walks, or I don't know. I think well, if you look at EMGs, the EMGs for rotation aren't as high in the small rotators as they are proportionally for the shoulder.
Mm-hmm.
So maybe add some kind of abduction with rotation component. I don't know.
Yeah, that's why I asked, because it's,
yeah.
I've sort of do those thought processes sometime where I'm like, all right, here's a joint that I don't deal with as much. What would be my kind of, if I'm replicating something that I'm comfortable with, like Jason said, is the adductor, the quad of for the quad of the hip. He's asking for Eric there. But sort of the idea. So the knee, everybody, the quad. Yeah, sure. The shoulder, we know the cup plays a role, and every joint seems to have a muscle that needs some encouragement to get back, right? Shoulder, deep neck flexors for the neck, maybe the soleus at the ankle, quad at those sort of things. Then we get to the hip, and I always just sort of, everybody, like a single leg step down feels really meaningful to me as far as the things that I'm looking at, especially if I'm loading the opposite side shoulder. But then, 6 weeks later, I might say, oh, a single leg deadlift, that's what's going to. So I was just curious your thoughts on it, because I don't know specifically what I would do as a one-off exercise there.
Yeah, I don't, well, my bias is either squats or deadlifts or something like that. And so, it- I mean, I think sometimes that takes a little bit, like if they're coming in one visit, like that's probably going to be hard. If you look at the literature and kind of maybe get into Jason's question is like more, so there's been multiple studies that have kind of looked at, okay, well, what muscle is the biggest one to be concerned about? It's a little bit dependent on who your population is. Probably adductors are probably a bigger thing. So if anything's going to be the quad, it probably is the adductors. If you look at work that we published, I mean, last Ishoy out of Denmark was the lead author. We found that hip extensor absolute strength was the biggest determinant of them returning to performance in sport. Now, some of this probably depends on like how you measure it, who your athletes are. Probably if I was going to look at all the literature and say one muscle, it's probably the adductors.
And are you doing adductor measurement isometrically in supine with handheld dynamometer?
Yep.
Do you have?
And,
yeah, go ahead.
And so like how we did in the study is the guy was holding it, his elbow was fixed against the wall for both abduction and adduction.
Yeah. And make sure the other leg is not able to contribute anything.
Right.
Yeah, that clinically, I'll have people drive their hand into the table and then lean down on it, and that creates the post that they measure into. Were you measuring at the knee or the ankle for that?
Ankle.
And do you typically look at torque with that, or are you looking at just force and looking symmetry?
Yeah, well, so in that study, we used a microfit. We looked at torque. We did also look at rate of torque development, which I'm not sure. Like, I think that's a little bit more iffy. I mean, you can speak better to that than I can. But yeah, and what was interesting in that study is we looked at torque. We looked at rate of torque development, and then we also looked at RSI with like when the MyJump app, and we compared surgical leg versus non-surgical leg. There was no difference. I mean, the differences were minimal in strength, except for when you pulled out extension absolute torque, which I'll talk about in a minute. Within rate of force development from I think 0 to I think it was 100 milliseconds. For flexion was significantly different for significantly lower or slower for flexion than non-surgical leg. And then, oh man, I should have read this paper again. But I think RSI was similar. I don't think there's a difference on RSI. But my point is that even though rate of torque development was lower, the thing that was discriminatory was the hip extension torque was now this is one study. I personally think there's issues with handheld dynamometry and torque, and I mean, you can speak to that better than I can. So, but I thought that was interesting.
Yeah, that is. How were you measuring the hip extension torque? Was that prone or
prone? And then we actually used a belt on extension.
Okay.
And then the dynamometer was underneath the belt. Yeah.
Gotcha. Completely random. But speaking of hip dynamometry, what I tend to find is if I have limitation in abduction on, let's say, the right hip, then I will almost always find a limitation in a deduction on the left hip. Do you see that ever? So it's a pat like it replicates to the opposite hip with
frontal
the
plane
opposite
in one
movement.
direction. Yeah. Well, to be honest, no, but it doesn't. Maybe I'm just not looking for it either.
Yeah, or maybe I'm looking for it, but it's almost always that sort of pops out in people who do, change of direction, cutting type stuff. But it's just become one of those things I'm like, I don't know why, but I see it.
So have you seen a correlation on leg dominance? No.
Just whichever side is injured. And injured, but more so weak, right? It could be injured and not weak, and then I'm not, but yeah, injured and weak, and then the same, movement, the same direction in the coronal plane, the other side. Yeah, no idea why. Just it's a weird. I
Yeah,
was
that's
hoping you had
interesting.
the answer.
Now you're making me probably going to go through all my data again tomorrow. So
That'd be cool to find out.
yeah,
So hip extension, that's going back, that exercise. What is a good program, right? So the idea that maybe not a one-off. Let's say, since the hip is a little bit different, maybe a squat or deadlift, squatting or hinging pattern at the hip is good. And then if you're going to add your second thing, because one of the things that gets me is, if you want to make a room full of PTs laugh, say something about non-compliance with home exercises, right? But is that a reflection on your patient, or is that a reflection on your ability to create a home exercise program that is doable and meaningful for them? And that's where my compliance gets a whole lot better the more I understand my patient and let them have a hand in designing the home exercise program. So if we're thinking, minimum effective dosage, minimum viable product here, if you have 2 to 3, I know you said the adductor seems to be key. What about the hip external rotators? That's another big area. Is that big because it was studied a lot, or is it actually important?
yeah, good question. No, I absolutely agree on the compliance, and like I've learned that the hard way too. And like I used to be the person that gave 9 exercises, the 9 exercises that I wanted them to do, and there's really good data showing that it needs to be meaningful to the patient. So like I'll typically is say like, what do you like to do? And if they're like, hey man, I just want to run, I really don't want to do exercise, like I'll probably try to give them a couple simple. That's why I said standing hip abduction earlier.
Mhm.
How I would kind of target external rotation is I'd probably have them externally rotate at the same time. So, but yeah, there is some stuff with external rotators, and um, what I find, it's probably a little bit different depending on how they measure it. Just, are they in 90 degrees of flexion? I've seen some people do it like long, like I think you're recruiting muscle groups differently that way. But yeah, definitely personally kind of biased towards what I would call closed chain. I mean, you can argue about what's closed chain and what's not, but
Right.
more like functional type of
Mhm.
exercises. So squats, lunges, and then like I would probably pattern like chops and lifts, which
Mhm.
I would say would bias external rotation. So that's probably where I would go if the patient was okay with that.
No, that makes sense. Yeah, I, this is something that I constantly go back and forth on. I'll give 1 or 2 things, and then I'll get like, oh man, maybe, I know I'm not actually addressing this thing with, all right, so then here's 5, but they were not going to do 5. All right, then I'm back to, and it's just that sort of dichotomy of maybe some patients just aren't going to get the best program because they're not interested in doing everything. But yeah, it's fun to think about, but then irritating to implement, right?
No, it is. And so like and this doesn't work for everybody, but like um, like if it's, somebody has a little kid, I say, well, kind of show me how you would pick up your little child. And then I say, well, okay, see that why that's like, I would try to relate it to functional task, and squat pattern, lunge pattern, deadlift or something, and I say, okay, this is why I want you to do that exercise. And
Hmm.
then okay, you literally pick them up here and you bring them this way, which to me is getting my rotation. And like I don't tell them that, but like that's what I try to accomplish. So
Yeah, I think, and you've posted some of this. I think one of the posts you had today was whether or not people felt, was it meaningful? I'm blanking the post that you tagged the SIG in.
oh yeah, just yeah, it was non-surgical trial, and some people were still considering surgery and that type of
Mhm.
stuff. So yeah.
So, I mean, it's not hip specific, but it is because hips are attached to humans, and that patient buy-in, like, that is probably the most important part about exercise prescriptions is finding that? Is there anything, again, not to go too deep in that, but I know it's an area you've considered a lot and have a lot of input on, is when you're looking at that, that establishing the equipoise or whatever fancy words you want to mean you use to say that your patient believes that your information is meaningful, and you are making sure that you are, using a narrative that they resonates with them. Do you have any sort of things around that, specifically from an exercise prescription, but in generally speak fine too?
Um, I'm not sure if this is what you're asking for, but
I don't know what I'm asking for, so anything's
well,
good.
so let me. So there's, some people will talk about, like placebo and versus, a true placebo, as I understand it, would be like a sugar pill versus placebo effects, which are gaining therapeutic alliance, which are like kind of coaching the patient up a little bit. There's this really interesting guy, and he's doing some work with Chad Cook on his mechanistic study, and his background is more cognitive behavioral, but he think well, and our study is showing us that true specific effects, like what you do, is probably a maximum of 30 to 35% of the outcome. And like I posted this on Instagram quite a while ago, but there was a knee osteoarthritis study where they did acupuncture. Now, granted, you can argue, well, should you be doing acupuncture for knee OA and that type of stuff? But what they measured is the outcome due to acupuncture, and they have to do mediation analysis and all this stuff that don't ask me how to explain it, but like it was 31% of the outcome versus non-specific effects, regression to the mean, like all that type of stuff. And
Yeah.
being psychologically based, he says that you should use placebo effects. You should use a therapeutic alliance. You should do all this kind of stuff. And like Chad published his paper on, and I know I'm kind of going circuit around here, but he published this really cool paper on patients. So there was two groups. One group of clinicians believed strongly in manipulation. One group of clinicians believed strongly in mobilization. I think it was lumbar spine. And then both clinicians treated two different groups. And so the clinician that was a manipulator manipulated one group and then mobilized another group, and then vice versa. And what they found is the clinicians that manipulated got much better results when they manipulated versus when they mobilized, and the mobilizers got much better results. Probably now the next step would be, and so that kind of makes sense. The next step would be, well, match the clinician, the clinician that manipulates to people that believe in manipulation. And then that would be placebo effects, and you would get like these larger effect sizes. So, so I'm
So
not sure if that's
basically,
what you're asking for.
no, Mike, I don't know. I'm just spitballing here. Like, these are the things, right? Like you said, it is. I forget who made the argument. It was a paper written a while back that I read probably a decade ago. But the placebo effects is the term that we use for things that we don't understand. It's not that nothing's happening. It's just like magic. Magic is everything that we don't understand, and then once we do, it's science. And plus, like, the argument seemed to be placebo effect is the same as magic in the broader setting, and it's not because it's not something happening. It's because it's our lack of understanding of what that is, and maximizing that is, I would say, avoiding maximizing that is a problem, right? Coming in, and everybody knows the surgeon who has the personality of a brick, brilliant surgeon, but the patient comes in crying because of their last follow-up. Nicely enough, surgically, probably, it's very, very structural, but even then the outcomes are going to change. And that, what is it? I believe how much you like the surgeon is the biggest predictor of whether or not there will be a lawsuit. It's not really the outcome. So all of these things are, very, very meaningful, very, very important. I don't know what I'm asking either. It's just more of a, like, these are the thoughts of how do we maximize this? So maybe is it just that B, you should have a system that you believe in. Maybe that's important. I saw a meme once about cognitive behavioral therapy is basically just gaslighting yourself. So maybe that's what we're doing here.
Yeah, well, and like I don't have the answer, and so like I definitely think you need. Well, I don't know if not sure how to word this to accurately surmise, but I think you would be a fool not to take advantage of some of that stuff. Where I personally struggle with is when am I coaching them up, which I think is a good thing, giving them support, saying, hey, this, this has good effects. I mean, you don't talk to them that way, but versus, and I don't want to pick on anything, but let's say a treatment that has really has no evidence at all, and then just like selling that, so how do you, I think you need to be perfect. And I think I've heard Eric say that you need to be perfectly honest and say, here's the evidence for this. I think in your case, you have no red flags, you have a good prognosis. I think this is a good way to, I think you need to be careful on how you frame it, but use it as a positive support, because the current literature would suggest that's probably doing more than what you're going to do to them.
Yeah. And our level of confidence in what we do and don't know is much, 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 much higher than the level of evidence actually is. So the thing that we are incredibly dismissive of, whether we may have evidence to support our level of dismissal of it. However, it is not quite as well supported if you actually, like you were saying, the return to play. If you start digging into the framework that a lot of these one-off papers are based on that we go marching forward with, it's definitely a lot shakier construct than what we'd always like to think about, I think. Get a question.
Well, just one thing
real
quick. I think it's important to do, you're starting to see some people do non-inferiority trials, which is essentially showing that, okay, this treatment is not inferior. I think some of that stuff could really help too.
Yeah, I mean, that's big in the drug literature, right? Because the idea would be maybe a cheaper drug that's no worse than something else. And we're always looking for what's better, but no worse is often good. So with low back pain, going for a walk might be no worse than any other intervention, and it's a lot easier thing to implement. So yeah, the non-inferiority to me is a very fascinating area. But since most of our effect sizes are so small anyway, it's pretty easy to show non-inferiority, right? Because nothing works. Force frame, and we'll sort of open up more, especially question and answer and bounce around as people have questions on this. But going back to testing, and I think this is a good one because it gets into testing one limb at once versus bilaterally, and how much the opposite limb is helping to fixate, the pelvis in order to pull off of it. So what are your thoughts on using devices like the force frame to measure hip adduction and abduction? Do you feel that you'd see asymmetry similar to testing with a handheld dynamometer, or I guess single limb would be handheld dynamometer or anything like that that's single limb? Or do you think that symmetry, because you're testing simultaneously, will be different?
I mean, I can only say so when I was in the training room, we had we had everything. We had force frame, we had force plates and everything. And so, and we just did our own little 15 athlete type thing, and we didn't see a big difference. And I know that Vald, the company that built is, so one thing I like about Vald is they're pretty much everything is proprietary a little bit, right? And they are too, but I think they are accepting of other people doing research on their type of stuff. And they believe that there is not a big difference. I do think and I think you would agree, and I think you could probably talk to us better. And I think how you set the person up, how you stabilize, all that is huge. And that said, there's going to be some inherent testing bias, right? If you don't put your elbow against the wall, if you use a belt and there's a little bit of slack. So probably technique is probably a bigger thing. I don't know. You can speak on that.
Yeah, no, I think you're right. I mean, the reliability is about how you perform the test. All of these devices are capable of being much, much, much better than we will ever be. Unless, I mean, maybe a crane scale. That's the one where I'm still not sure, because it's not designed to measure instantaneous. It's measuring a static load. But anything that's sampling at a reasonable rate and designed for testing force output, yeah, it's going to be much, much better than you are. So do the best and then repeat the same thing you do every time. I don't know. I think that's an interesting question. I've very briefly dabbled with it a little bit, and yeah, it's kind of if the torso is fixated, or like that's maybe a lighter person being able to pull their body across a little bit easier, you might see a little bit more from those sort of things. But I there's also the bilateral aspect. So like if you're doing a bilateral force plate test versus a unilateral, you'll typically see, like with a counter movement jump, you'll see higher forces frequently with the bilateral, because the other leg is kind of um, coaching the opposite leg. So it basically tricks your body's willing to risk more, and then the injured limb has to do better. So
Right.
I don't know if we would see that in here at all either. So you did use it for a while. Did you like it as far as, or did you stick with your sort of unilateral when you had this option for it?
So to be honest, it probably like depended. Like if we had 15 guys in the training room,
Yeah.
like I went straight to handheld dynamometry. And
Yep.
so, I mean, it was just, if we were messing around and we had time, and we would probably do that. So
Yeah, that makes sense. That's the biggest thing about technology is how long it takes to set. Like if it takes more than a minute to set something up, chances are good you will not use it in a general setting.
right.
And even handheld dynamometry, like if you just have to say that part of my process is dynamometry, and then whenever you see someone, you just have that with you. I mean, I'm sure you found the same thing. Is initially it's like, oh, I use this when I think there might, and then you never use it. But then you're just like, all right, I need to screen for these important range of motion, force output, swelling, special tests. And if you get those cleared, then you're like, oh, maybe I don't need to do all the other stuff that I normally did.
Well, like one thing that we would run into, I mean, you got huge humans, right? And playing football, and like we typically didn't have a wall to put our elbow against. And so like we would try to get in stride stance, lock it against our hip, and there were several times where they would push us and move us. And so, all right, go get the belt out. So now it's like something that took 1 minute is now taking us like 5 or 6 minutes. So,
Yep. And then there goes extra time. Circling back while we're waiting on questions, and if anybody has questions, please do pop them in there. Mike's a wealth of knowledge, so ask away. Hip micro instability, something you hear, you don't hear. Curious your thoughts on that.
it's a very debatable topic. I think well, so I know there's been a few videos like showing the suction effect of the hip and all this type of stuff. Like if you've ever been into surgery, it takes a pretty good amount of force to distract the hip. And like I'm not exactly sure what micro instability is. I mean, as far as like how you would define that, I think, and what we put in our consensus paper is, I forget how we worded it, but essentially is like dysplasia is a component of, I mean, either have non-contractile stability and, contractile contributes to that. I definitely think I have people that have a lot of motion, have symptoms similar to what they would describe in shoulder instability. And so maybe that's what we could call, micro instability, a lot of, so it's, this is a person, some of the literature is showing that how important total range of motion is in the hip, just kind of like the shoulder. And then, somebody has a lot of total range of motion, has some of the complaints of instability. There are a few tests you can do for instability. None of them are very good statistically. They make sense from a practical standpoint. I would say that I treat for what some people would probably call micro instability. I don't know if I personally call it that, but yeah, I mean, it's, somebody has a lot of motion, They have a ton of external rotation. Their leg just kind of flops out to the side. They have no redundancy. When you like roll their leg and let it go, it just like flops. They might have some, you put them in extension, external rotation, pass neutral, they start having some apprehension, similar to like some of the shoulder tests. I mean, I assume that's what most people are going to call micro instability.
Gotcha. Yeah, I mean, it's an interesting, like, that, like you said, everybody's seen the video of how hard it is to dislocate, but that doesn't necessarily mean that there's not a control component, because I'm assuming if you injected and just did a nerve block everywhere there, you'd see a difference in that. Do you utilize a list of objective and subjective criteria prior to beginning a return to run progression following hip arthroscopy?
Prior to run,
Yeah.
yeah. So we probably so there's a oh my gosh, I can't think of the paper. There is somebody has published on this stuff, and well, Dan Lorenz has published on sprinting,
Mhm.
but there is Ramad, I think, Rambod, Rambaud, or something like that. Claire Ardern is on that paper, and it was for ACL. And so we tend to use similar types of things. At Duke, we do have our university, like our sports medicine department, has a return to run program. It's like run this much for a couple of days, take this day out, and that kind of stuff. So I kind of use some kind of combination of that kind of stuff, but it's more of what I like to do is when I was in the training room, we another PTATC came up with this, and there's you can come up with your own, but we came up with this app where the athletes would fill out, really simple visual analog scale, 0 to 10. How sore am I? Just kind of like how much pain do I have, and just how well did I sleep? And then we would tend to probably adjust our program based a little bit on that. And so that's how we would kind of do with our running as well. There are issues with that, of course. If somebody wants to run, they'll probably chink it a little bit. If somebody doesn't want to work out very hard, they'll, if they know if it's their heavy day, they might say they're more sore or whatever. But it is definitely a combination of subjectively what they're telling you and then objectively what you're finding. The problem with the hip is like, well, same as a shoulder, you can't see swelling like you can see in a knee or an ankle or a wrist and even elbow. So but I tend to find that people that, so I mean, they have to understand what the difference between soreness and pain is, of course, but if they have this deep, really deep seated stiffness that, and it's not necessarily osteoarthritic, but they behave somewhat like people, they get up, they're stiff, they start moving around, they start feeling a little bit stiffer, they're doing some activity, they start to loosen up, but it's not non-touchable, it's like deep in the hip. Like I start to think in the back of my mind, maybe a little bit of effusion or something going on. And we kind of look at how they run and move and that kind of stuff. If we see similarities where they're not like that, then we tend to, so like if they were doing like X amount, we would probably, and they were supposed to go up to Y, we'd probably keep them at X. It would need to be pretty bad before we would go back down one level, but it's very non-scientific, I guess.
Much more clinical. Yeah. But and I'm not aware of this, but do you have like specific strength metrics that you're looking for at the hip? Like here is the goal. I know we should never dichotomize continuous variables, but we like to have metrics that we can poke at and say, yay, we finally arrived, we're good. Do you have any particular ones at the hip that you're doing strength wise or range of motion?
For range of motion?
Either it's strength or range of motion.
Yeah. So, well, I think the issue with range of motion is what does the infield feel like? And because like if I examine our basketball team, like hardly any of them have, internal rotation past probably 5 degrees. And so it's just like but it's a hard infield. And so a big bias of mine is like, why are you continuing to crank on that versus just like strengthen it through that available range of motion? from a strength standpoint, there are some published things, and they're pretty dependent. So like Christian Thorberg has published some stuff. Andrea Moser and Andrea Cerner published some stuff. They're either semi-professional or professional soccer players. There are some numbers on dysplasia, and typically extension. So it's very variable, males versus females and that kind of stuff, but extension probably needs to be like above 2.0 newton meters per kilogram. Abduction is anywhere from 1.2 in some dysplasia patients to like 1.8 in some of Christian's work. And then the others are pretty much the same except for flexion. Some studies are suggesting it might need to be a little bit higher, but like it depends on how, did they do it supine with 90 degrees of flexion or were they sitting? So, but those are some general numbers. You can, I mean, typically extension needs to be the highest.
Right.
And then the other three, well, abduction, adduction, and flexion are very similar, but probably in the 1.2, 1.5, 1.8, depending on who your cohort is and how you're doing it.
Yeah, that makes sense. I had not heard flexion being in there, but it kind of makes sense, generally speaking. The old bodybuilding ratio was your neck, your biceps, and your calves should all be the same. So we'll just have the hip ratio be your abduction, adduction, and flexion be the same.
Well, so there are some studies in like I know Tim Tyler's published on this. I know Christian has published, Christian Thorberg, and I'm sure other, but you know, the adductor to abductor ratio and how it adductor. I mean, this is why I think you got to be really careful about who you're looking at. And so, like for example, like when I published my exam book, I think the one thing I put in there that I thought a lot of other books were missing is like, well, who's the cohort? Like, who are they examining? And so, like, but in those studies, primarily soccer players, adductors do need to be. I think I've seen sometimes as high as 1.2 to 3 to. I think one study showed 1.7 times higher. So,
Wow.
you definitely, and that was probably in hockey players. I don't know.
Yeah, that would make sense.
You definitely need to look at who you're examining.
Yeah, but yeah, definitely kind of like with the shoulder, internal rotation should be higher than external. The exact ratio is kind of, up for debate. That's kind of how I approached the hip. You should have a little bit more adduction than abduction. Ratio wise is, to your point, really depends on what you're dealing with. Continuing that from the range of motion thing, Michael had asked, when you're considering the hip rotation capacity, do you have a total arc of motion threshold that you attempt to achieve, like 80 degrees or something? And if you do have a total arc threshold for hip extension, do you also have one for flexion, or how does that work?
Yeah, that's a great question. To be honest, I don't. So Igor Tak, TAK, published on this. So if you want to look it up, and if they want to email me, I can look it up and find it too. I don't remember, but his point was, well, before that study, so he published a cohort study, and he also published a systematic review. I don't remember if it was a meta-analysis or not, but and both of them kind of concluded similarly. But before that study, or before those studies, everybody was saying, well, internal rotation is the problem. Here's what's fascinating, Scott, is like all the stuff that we said in the shoulder, like 15, 20 years ago, we're starting to say in the hip. And it's like, why can we not learn what we learned in the shoulder? But anyway, is, so the big variable is, okay, internal rotation is a big problem. It's the, if they have a large femoral head, a large cam, that's going to limit their internal rotation. And there are some studies that show that, but there are some also other studies by Krautler, and this is my personal bias, is that I think torsion is a bigger determinant of rotation limitation. And then cam tends to be a limitation more for flexion and extension. Mm-hmm. So what I personally look at is I have them sitting, and you can do it. I think in the study they may have done it supine. I like to have them sit, and And then I look at internal and external rotation. And what Crowther found is if there was more than a 20-degree difference in internal versus external, so like if, I'm not good at quick math, but if internal rotation was like 10 and external rotation, like I'll just make it extreme, was like 80, that's obviously way more than 20, then that's a torsion problem. And so if they're anti-torsioned, they would have a lot of IR. If they're retro-torsioned, they would have a lot of ER. So in that example I gave, that person would have retro-torsion. And so, but to me, you also have to look at how you got there and then what does the infield feel like. So if you're going through the range of motion and they're guarding, and you can tell it's like a muscle, for lack of a better term, spasm within range and infill, like that's probably not their in range. So like I'll try some contract, relax, and sometimes it'll come and not, but like it needs to be in range. And then, but to me, like and again, that's just one or two studies, but that's how I use range of motion. But, and I don't know the number that Igor Tack, I don't know if he put a number on it.
So
But,
I think I have the right study. I uploaded it to the chat, the PDF of it. It's the risk of groin pain based off of hip range of motion, BJSM. Yeah.
So there's a systematic review, which I think is that one, but he also did I think he did a cohort study as well. But yeah, that'll be a good.
Yeah. Interesting. Yeah, that's I mean, it goes to with the whole FAI or impingement being limited flexion extension, kind of thinking, at least my typical progression is heavy box squats high, and then we progress depth based off of tolerance. So we're still loading it, and it's just limit the range of motion. And then we talk about your activities of daily living, like the guy who sits on the bike with the low seat and wonders, oh, my hip always hurts when I do exercise. And, just those things, getting in and out of the car, especially if they have that low car and they're a bigger person, they get that internal rotation and flexion when they're getting out. That's limiting range of motion. So they stop pissing it off and then loading it up. And that would make a lot of sense from what you were saying there. We had another question about handheld dynamometries. Any recommended resources or places to look for info on setup and stabilization techniques and norm reference values? Any centralized place that has all this info in one place? I do
Scott's
have
website.
most of this stuff up. Yeah. So, if you go to the website, I have that. I also, the Instagram account has a bunch of the videos. I'm in the process of filming some updated one with Tindex, so you can see, because a big question I get a lot is people small clinic, don't have as big of a budget. They'll buy the Tindex and then they're like, I don't know how to do the push setups with it. It's actually really, really easy. You just put a belt on, you strap it in place, and it's more stable because you're holding off of your body, like Mike was talking about, bracing on the wall and stuff like that. So anyway, there will be more updated. And I don't remember I think I have a video up there where I talk about this. If not, I can put it out there as well. So yeah, there's a lot on there. As far as if you want to see particular setup and stabilization, like look at the study Mike talked about him doing. There's going to be a description in there of how they did that setup. And also it's a very easy, if you want to replicate what they found, especially if you're using the norms that they use and your population is, obviously make sure your population is similar, but to Mike's point, you can expand on this. That's if you're using the norms and you don't have the population and you don't test the same way, having norms is pretty much useless at that point to me.
Yep.
Mike, completely different thing, and I know we're kind of at the top of the hour, so if we got any last questions, make sure to pop them in there. Anterior hip discomfort, rectus femoris insertion versus labrum. Is that something you differentiate between?
Rectus femoris versus what?
Like labral.
Like labral.
Yeah. So like if they're getting that pain in the front of the hip, right? Do you ever like differentiate out or treat it from a like loading the rec fem in a lengthened type position, or?
Yeah. So, well, I'll try to answer this. But essentially, is if you look at the anatomy, is the psoas So let's take like a right hip, for example. The psoas runs directly in front of the labrum. So like if you took a clock and, the top of the hip is 12 and the bottom, superior is 12 and inferior is 6, anterior is 3. The psoas runs directly in front of the labrum at 3 o'clock. And so what's very interesting is when the first studies that came out on labral pathology, they were reported as this 12 to 130 position, which is kind of this anterior superior, mostly superior. And so the proposed theory was, well, it's an impingement. The femoral head is jamming up against there and impinging, which is crushing it and tearing it and like all that stuff. Now, what you're starting to see more of, reported at least, in the surgeon I work with sees this too, is you're starting to see more 3 o'clock labral tears, which, is that, they're getting a lot of extension. Is that something related to the psoas? I mean, what is that? And again, compared to the shoulder, if you look at how some of the stuff came in the shoulder is, the back of the biceps would always be red, it'd be irritated, so they would start doing tenotomies. Versus like, well, why is the back of the biceps red and irritated?
Mhm.
So now you're starting to see the same thing in the hip, is where they're resecting the psoas because it's red, it's inflamed, it's irritated, and it's thought to be the pain generator.
Interesting.
Yeah, it's fascinating. And so as far as rec fem, like if I was suspicious, like that wouldn't be a bad idea to try to strengthen it and see how they tolerate it. I would be more suspicious of labral if they had consistently clicking and catching.
Mm-hmm.
The problem is though, is that labral, or is that the psoas snapping over? And so like, I think if you keep it relatively in the sagittal plane, because most of them get it with transverse plane, which, so there are people that describe internal snapping hip, which is the psoas snapping over the femoral head. Like, I don't know how prevalent that is, but mechanical symptoms would lead me more towards intra-articular pathology like labral
Mm-hmm.
versus not. But I still would train hip flexion, rectus femoris. I would just, so there's some really cool biomechanical studies show that the psoas is a hip anterior femoral head stabilizer anywhere from 0 degrees of hip extension beyond, or actually 15 degrees of hip flexion to more extension. So like I would just stay above that. And
Okay.
I mean, they're usually painful there anyway. So I would strengthen above that range and try to get some physiological overflow.
Interesting. Yeah, that's cool. That question comes from having worked with Eric Mara. One of the things that he had mentioned and that I've started implementing over the last however many years now is sort of a prone knee flexed loading of knee extension. And when you get a lot of that anterior hip irritation, that's like, oh yeah, this is the spot that's hitting it. And just seems like one that, for whatever reason, especially the people who are always doing the stretch where they're like, oh yeah, I try and get, that seems to be something that, yeah, just as a one-off for whatever reason, he
Well,
mentioned.
they're pretty locked down that way. So
Yeah.
it's,
Yeah.
versus
Mhm.
like Thomas test or something like that.
Right. Yeah. You got 2 last questions, and then we want to be respectful of your time. Do you have a couple minutes to hit these?
I'm
And
good. I'm good.
all right. So actually, let's do Shelby's first, and then we'll finish on Michael. Michael says top 3 areas for improvement or misconception where the profession can improve in regards to hip rehab. I think that's a good one to end on. So Shelby, Mike, any instance where diagnosis equals not directly loading the area that's angry? She treated a kid that they had thought was adductor related groin pain. They pissed off the groin and turned out he had osteitis pubis. A mentor encouraged her to not load that area directly to let it recover. Any other instances of that in the hip?
No, like I try to load everybody, and like even really pissed off, irritated people. Just a really quick side note is osteitis pubis is a very interesting term, because like where it came about is, like, I'll try to be brief here, but it's it came about in the soccer studies where how it was diagnosed is people had they had edema on their pubic bone. And that was the criteria. But then they did subsequent study. I mean, this is how we do a lot of stuff is they did subsequent studies and found out, well, if you just train hard, you have edema on your pubic bone. So, so I'm not exactly sure what osteitis pubis truly is. I mean, there's definitely surgeons that talk about it. It talks about if the disc needs to be inflamed and irritated. But short answer is like I still load them, whether it's isometric, short range. Like I would not back off of it. I would find it a more comfortable, tolerable way to load them.
Yeah, I almost always, for me, something being irritated by load is a sign of dosage, not the thing that you did was wrong. In fact, like kind of like with the manual therapy mindset of if you do something and it flares things, well, you actually address the thing that was driving some of the symptoms. So now it's just a matter of figuring out how to dose it. The whole peace and love blog that BJSM did, I think, does a pretty good job of touching on some of these ideas of it's that holy search for the Goldilocks level, right? It's never about not loading, because as long as you're alive, you're responding to stimuli, and we got to stimulate in order to move it. And then, taking us home with the top 3 areas for improvement or misconception where the profession can improve in regards to hip rehab.
A great question. Well, let me go back to the Greenberg study with ACLs. I guess I would try to answer this with asking some questions. Is if we've been treating ACLs for a very, very long time, and I think that article was published in 2018 or 17 or somewhere in there. If we have multiple OCSs and SDSs that are using manual muscle testing as a strength measurement for return to sport, and we've been doing that, and we know much more about ACLs than we do about hips. Like, where do we think we are for hips? And so I think one of the biggest things is get informed. I mean, be informed. Just use good evidence-based, which is limited, but use good progression principles. I think make sure you're loading people appropriately, kind of like what we were talking about. But I think that is probably one of the biggest things. So the patients that, maybe I'll try to answer it this way as well, is the patients that I see the majority that I see are patients that have had rehab multiple times and or have had at least one surgery and are not doing well. And probably almost every time is they've pushed them either too hard or so the Goldilocks rule is either they don't do anything with them because they're kind of scared to do it, and or they just put them back to, like, I like CrossFit, but they put them back to CrossFit like way too soon or something. So I think listen to your patient, listen for the problem with hips is you don't see swelling, but like I talked about earlier, is that deep-seated C-sign stiffness that gets better and starts to loosen up. Those are things where, okay, maybe we're not progressing today, we're staying the same, and using some of those kind of general rules. I think maybe all 3 things to answer that question would be, we need to do better studies, number one, so we have an idea, because our studies that are non-surgical are way behind the surgical trials, and the ones that are out there are, about half the patients that go through it. Well, 70% of the patients are satisfied, but 40 to 50% of them are still considering surgery. So, and I'm not sure what that reflects on. Is that the program or is that the patient with too high of expectations? But I would say just being better at rehab across the board.
Yeah. I mean, go back and read that 2011, 2012 paper that you and Dan wrote. I mean, the principles are applied loading is still applied loading. Physio, we don't evolve that fast. The stuff that still worked for Milo back in the day, lifting his bull, progressive overload, and specific adaptation to impose demand. If you If something went wrong, it's usually that you didn't progress overload well enough, or the thing that you thought you were imposing the demand on was not what you imposed the demand on. Uh, one of my advisors, so doing a lot of coding stuff, and anytime I send code, I'm like, I don't understand what's going wrong here. He's like, the program does what you tell it to. Don't do this again, and they'll highlight that line of code. And so I like that a lot from if the adaptation is not what you wanted, your body's, think of your brain in a vat. It's sitting there. All it knows is what you tell it to do. So your body's reacting to the stimuli that you gave it. If it didn't adapt appropriately, it's because the adaptation was to impose the imposed demand. The imposed demand just wasn't relevant to the thing that you cared about. But yeah, never do this again is a comment I get a lot.
I think maybe one thing I would add here is if you look at the literature, and I would say this with the patients that I see as well, is a lot of these patients have had this for a long time. And a lot of these patients are frustrated. And so there's been a couple of studies published. Dan Ron, who was a colleague that I work with, published one, and the mental comorbidities in this group is pretty high, is pretty significant. And actually, what was interesting is this study is the patients that didn't do as well were the ones that had higher comorbidities, both physically but to a bigger extent mentally. So addressing the patient holistically is what I'm trying to get at here but what happened after surgery is those mental comorbidities actually exacerbated a little bit. And so what you have to consider is these patients have really high expectations for surgery. And there's some studies showing that they had Manning did this really cool study where he looked at expectations before surgery, then he measured them 1 year out. And he essentially did a fulfillment of expectations. Did they meet those expectations? They were not met, especially related to sports, pain, and physical activity. A lot of patients 1 year out have actually decreased their physical activity. So keep them physically active, keep coaching them up, address them holistically, and progressively load them like we talked about. But I think the biggest things that I work on is like I try to give everybody work capacity. And sometimes low hanging fruit is just, are they getting 150 minutes of moderate activity a week? And then, for most patients, anything above that is good. Right now, if I'm in a training room, then we're doing work to rest ratios. We're looking at that type of stuff. But I think if you can give people a good foundation, like Scott told me one time, a big, strong engine, whether that's mentally, physically, or socially, I think that goes a long way.
I like the way Dan John talked about work capacity when he was on. He said it's really hard to define, but the way he explains it is you come to your house, your car's full of groceries, and you can make the decision to either take them all up the stairs in one go, or you can take them all up one at a time, and you have the ability to do either of those. That's work capacity. Is you can kind of handle what life throws at you.
It's a good way.
Yeah, Dan John is brilliant.
Dan John wisdom there.
Yeah, right. Dan Johnism. Thanks, Mike. That's incredibly great. I may get you on again to talk about, because like you said, we could do a whole thing on some of these particular areas, and the conversation can always go forever, but it's always good to hear that other people aren't sure either.
Yeah, I mean, I think it's like I give all my students first day of MS class, I give them a couple articles on tolerating uncertainty.
Yep.
And I think it's hard. I mean, it's like I've been out a long time, and sometimes it's just kind of hard to say, well, just what's the minimal effective dose for somebody that's really red, irritated. And sometimes it's just like, hey, dude, you're active for 20 minutes a week. Let's just try to bump that up a little bit.
Yeah. And we don't usually plug things and all, but check out what Mike has. Like his Instagram is great, puts out a lot of great content. Machine, when it comes to research, I think you published like 40,000 systematic reviews during your time of your PhD, something like that. It's just every time I turned around, another one. But Mike also has, the, what is it, Rehab Learning Center? Is that yeah. some great stuff involved, mostly because I did a guest lecture once, so that's why I think it's great. But beyond that, I'm sure they had other mediocre guests too. But yeah, it's just a wealth of wisdom. Definitely go back and read that original paper on strength and conditioning and rehabilitation. I think it was one of the earliest ones that really sort of started getting that conversation going around it, at least that I know there have been some before that, but that's maybe the last decade or so really prompted some of this high level of interest around this area and helped put our SIG on the map.
Yeah, Dan was your founding father, right?
Yeah, we the Godfather, as he is known
The
here.
Godfather.
The Godfather.
Pretty young to be a Godfather.
I know he doesn't really like it when we call him the Godfather, so I insist on it. All right, next one we have coming up soon. Shelby, do we know who that is at this point?
Negative.
Okay, I have a couple people pending, so we'll get it and we'll push that out. But thanks everyone for showing up. This will be hosted on the website and then also pushed out onto the podcast later. So